Story Slam, highlighting the opioid crisis, brought to you by the Frontier Nursing University Institute for Healthcare Improvement Open School Chapter. My name is Lana Burnett, Virtual Coordinator from Hawaii, and I'll be serving as your moderator today. Working with me is Sydney Markman, an APRN from Seattle, Washington, who is the Frontier Nursing University Institute for Healthcare Improvement Open School Chapter Chair. Sydney will be monitoring and relaying your questions and comments from the chat box. I would like to recognize Frontier Nursing University faculty advisors, Dr. Diana Jollis and Dr. Judy Butler, who are joining us from a live site in Tucson. We also have a group from New York City hosted by student Bree Farron joining us. Leading us in this endeavor is Dr. Julie Marfell, family nurse practitioner and Frontier Nursing University Dean of Nursing, who has a brief comment. Dr. Marfell, thanks for being here with us.
Thank you very much, Lana, and greetings, everyone. I'd like to thank you for your leadership and support in actually starting the FNU Institute for Healthcare Improvement Open School Chapter. This past May, I should say, Frontier Nursing University took the White House Opiate Education Pledge. Our students are educated to use evidence-based guidelines and state regulations to provide pain management for their patients. This includes all methods of pain management, not just medications. Students at FNU are taught how to assess for possible abuse of pain medications and assist with recovery and treatment plans when necessary. As part of this ongoing initiative, we are excited to participate in this year's Story Slam. Your commitment to healthcare quality is greatly appreciated, and I look forward to hearing the presentations this evening. Thank you so much.
Thank you, Dr. Marfell. The theme of this year's Lown Institute RightCare Action Week is Listen. You'll be hearing some brief stories from 3 individuals today on this timely subject. You will also have an opportunity following these stories to share a story of your own, ask questions, or share successes from your communities. Before we get started, I want to take a few moments to acknowledge the Lown Institute and RightCare Action Week. We acknowledge that our healthcare system needs help to deliver the right care. To quote the RightCare Action Week goal, healthcare that is effective, affordable, needed and wanted by well-informed patients, and especially free of clinical decisions that are made with financial or business considerations. RightCare Action Week gives us an opportunity to collaborate on what healthcare can and should look like. With RightCare Action Week in mind, we selected the opioid crisis as the subject for this story because we acknowledge the complexities within the healthcare system as well as our communities that have contributed to the problem. More than ever, we need to consider how to partner with each other. This is the common ground that brings us together today to hear these stories and discuss what we can accomplish together. Moving along now to our session, please welcome Benita Jones joining us from Arizona. Benita Jones has been a registered nurse since 1989 and is a board-certified acute care nurse practitioner working in a pain management setting for over 3 years. In addition, her doctoral work has been focused on integrating exercise to address chronic pain. Benita, thank you for being with us.
I'm going to start with this. It is well reported that the United States uses over 80% of the world's narcotics, including 90% of the world's hydrocodone, but we account for only 5% of the world's population. 75% of all prescription medication overdose deaths are due to narcotics, and there are more deaths from narcotics than heroin and cocaine combined. 100 million Americans have non-cancerous pain. Pain is the #1 cause of work disability at a cost of $635 billion per year, which includes doctor's visits, missed work, transportation, and family costs. The overall medical cost of pain is almost $300 billion annually. In June of this year, the AMA stated that pain should no longer be considered the 5th vital sign and advised their members to take some ownership in the current opioid epidemic. The Joint Commission denied that they were holding hospitals accountable for treating pain until patients reported a pain score of 0, and discussed how their efforts to ensure that undertreated pain was adequately addressed was not a factor of the current opioid crisis. They are quick to provide research that shows that the number of opioid prescriptions had been steadily increasing before the recommendations in 2001. Then there are the now unsubstantiated claims from pharmaceutical companies such as Purdue that touted that OxyContin had a low addiction profile and was more effective than short-acting narcotics. As you can see, there are many reasons for our present crisis, including laying some responsibility on the consumers themselves. To put it bluntly, it doesn't matter how we got here, just that we have a serious issue, and where do we go from here? The opioid crisis has hurt every ethnicity, culture, religion, socioeconomic status with every town, city, or village, not only in America, but across the world. Fortunately, addressing this crisis is a multidisciplinary task, and advanced practice nurses are based guidelines in place, including the CDC, the AHRQ, and even President Obama has addressed the epidemic. First and foremost require appropriate initial assessment and initiation of non-narcotics such as anti-inflammatories, also stretching and physical therapy and interventions as needed. Narcotics, when initiated, should be at the lowest dose for the shortest amount of time. Narcotic agreements and urine toxicology should be performed. Prescription monitoring profiles should be viewed every time a narcotic is prescribed. The availability and use of naloxone for clinicians and laypersons is also encouraged. Most importantly, addiction and behavioral health services should be an integral part of the process, but unfortunately are lacking in most Medicaid programs. There is much to be done, but we are up to the challenge to ensure that patients are treated with respect and dignity while attempting to safely manage their pain. As a pain specialist, it is my role to create a comprehensive multimodal plan of care for persons with acute and chronic pain states. This includes post-surgical pain, palliative care, and acute on chronic exacerbations. My care includes appropriate referrals to other members of the healthcare team, including but not limited to addictionology, surgery, neurology, and chiropractic care. This can become difficult as some modalities or medications are not covered by Medicaid, or it can be cost prohibitive to those with commercial insurance. My personal passion is physical activity. Research shows that increasing physical activity can not only decrease pain, but is great for cardiovascular health, stabilizing blood glucose levels, and can be part of a plan which can decrease depression. However, conventional physical therapy can be difficult to attend due to financial, transportation, and even time constraints. Fortunately, there are low-cost options such as Silver Sneakers, which is a national program for persons over 55 with commercial insurance that offers free or low-cost gym memberships. Also, Go for Life is a free federal program that offered by the NIH's National Institute of Aging, which offers free exercise DVDs, workbooks, and internet resources. These can be sent directly to your practice or to your patient's home without cost. Now, there are times when I get discouraged as I feel as though I'm fighting an uphill battle as I attempt to follow guidelines to ensure that I prescribe narcotics safely while attempting to manage the needs of my clientele. Then I will somehow get someone, such as a 60-year-old with chronic pain, who explains to me that they're ready to wean some of their narcotics as the interventions have helped their symptoms, and how she truly enjoys Silver Sneakers, which has not only helped her to be more active, but have helped her meet some new friends. I have patients who thoroughly enjoy the Go for Life DVD as they are able to have a structured exercise program that's free, and that makes it all worthwhile. And I know that I'm in the right specialty. Thank you.
Benita, thank you for sharing your story and giving your perspective on the opioid problem. We turn now to Dr. Heather Ungehauer, joining us from Kansas. She is a board-certified family nurse practitioner who also has a professional interest in chronic pain management. Dr. Ungehauer, thank you for joining us today.
I'm happy to do so. My story is a bit different because it's twofold. I had an early experience with pain management patients when I was still early on in my master's program. My then 13-year-old son became extremely ill with extreme headaches, muscle spasticity, generalized inability to walk or speak well. We took him to the local emergency room for treatment, where he was quickly denied pain medication for his horrendous pain he was feeling. The physician at the time felt he was too young, and I repeat, too young to have that kind of reported pain. Instead, he must be a drug user. He made the assumption quickly and with minimal assessment. For him over and over throughout that night. We would later find out that the horrible pain he was experiencing and his symptoms, over the coming weeks, he would be diagnosed with pediatric MS. This is just one of the many reasons I'm passionate about pain management and the safe and effective care for patients. It's my belief that patients and providers have a joint effort in this epidemic. Providers need to be in a constant state of consideration for the mechanism of pain that they're treating. What prior experience do the patients have with opioids? Have they ever been treated with them before? Which means do they have already built a tolerance to or dependence to? Providers need to be using screening tools, such as the Dyer screening tool, which helps to assess if a patient is an adequate candidate for a long-acting opioid versus a short-acting. Is there engagement in other modalities of treatment, such as exercise, physical therapy, weight loss? Assess for illegal drug use. Don't assume that everyone that walks in the door is using illicit drugs or has diversion of their medications. Also look for underlying mental health conditions. There's a large population that is dually diagnosed or treating mental illness with opioid medications. All medications need to be started as a trial, not something that we just tell patients they're going to be on for the rest of their life because they're always going to have chronic pain. Always are changing. When we need to continue to reassess, this is vital. Remember, more is not always better, and we have a responsibility to educate our patients to the paradoxical effects of opioids. Hyperalgia is a very real factor, and pain can be worsened and enhanced by opioid medications. Set realistic expectations with your patients and make it an open field of conversation. It's okay for patients to express frustration, just like it is for providers to express frustrations. We're not always going to fix the pain. We can make it more manageable. We can make lives better, but we have to commit to our patients, and patients have to commit to their providers to be in this together, to form a safe partnership for the effective care and coping and management of their pain. For inviting me.
Dr. Ungehauer, thank you so much for bringing your experience to this forum. I would like to introduce you now to Dr. Sherry Long Romero. Dr. Romero has been a certified nurse midwife for 21 years, a registered nurse for 26 years, and in recovery for the last 12 and a half years. She joins us today to share her perspective as a patient. Sherry?
Thank you for having me. When I was first asked to share my story, I wondered about which story to share. I'd really like to just tell you about my story of redemption, how I've overcome impossible odds to regain so much of my life. But to really understand this, you would need to hear about my experience with addiction. My name is Sherry. I'm a drug addict and an alcoholic. In my late 30s, I had a thriving midwifery practice. I'm also a certified nurse midwife, a frontier midwife. I had 4 beautiful children, a 2-decade-long marriage, a house in the suburbs, a new car, a wonderful family. You get the picture. I was exposed to prescription drugs through an injury. Now, not everybody who gets exposed will become addicted, but there was something different about me. There was something in my midbrain, in my frontal cortex, perhaps in my genetics or in my environment that made me more vulnerable. And I became addicted in a fairly short period of time. During this process, I lost nearly every single person and every single thing that ever meant anything to me. I lost relationships with my children, my family, my peers. I lost my marriage, my home, and I walked out of a career that I was so passionate about and where I found most of my identity. I nearly lost my nursing license. I was sort of forced into recovery through a licensing board out of fear. That was almost 13 years ago. It's certainly not been a perfect road for me. Important things I found out for myself was that addiction is a multi-layered disease, and it requires a multidisciplinary approach for true recovery. I spent so much wasted time in white-knuckle sobriety, locked in fear and the requirements that were forced on me, that I didn't really find the joy in recovery. When I was finally able to utilize an advanced practice nurse as in my primary care, I started addressing some more holistic issues about my health. I found a psychiatrist and a psychologist who started delving into some of the bigger issues than what I thought was really just a moral weakness. I looked for sponsors that were more aligned with my needs. I also made myself vulnerable by sharing my story and being available to the still suffering addict. The nurse that was searching for a mentor in recovery, and the public who were looking for some kind of reassurance that we can and do recover. I would urge you as a call to action to submerge yourself into recovery culture, to go and sign the care letters to Congress who are in charge of the budget for that bill, to read the Bill of Rights that addresses the role of the addict in their own recovery, and utilize the nurse practitioners that we have available as primary care for pain management, for addiction resources, and the experts in holistic use for the client. I've made my way back to midwifery with help from numerous people who cared enough to reach out and give me another chance. The wreckage of my past stays with me and has to be revealed and explained to people who don't always have my best interests at heart. I have been willing to give them access, though, to some of my most personal histories in order to be allowed to serve the community as a nurse and as a midwife in grateful recovery. My hope is that by doing so, there'll be a greater understanding of my story, which will lead to better access and more acceptance by the healthcare community for people who are searching for recovery. Thank you.
Sherry, thank you for sharing your very personal experience with us. I'm sure it will touch many. At this time, we are going to transition to our breakout sessions for discussions. Tucson and New York City, thank you so much for tuning in. We hope your group discussions go well at your sites. For all who are going to continue with our virtual presentation, we invite you to share your story, pose questions to the presenters and general audience, or share successes that you may be experiencing in your communities. So if you want to do that, please type your name, location, and comment or question in the chat box, and Sydney Markman will share with the audience. We're going to open the comments with Kevin Alexander from California, who is going to spend a few minutes explaining his experience and expertise with community partnerships. Kevin, the floor is yours.
Thank you very much. So, I am a doctor of behavioral health, licensed clinician. I've been practicing for about 20 years, and my experience with addiction started very early on in my career. I found my passion in treating addiction while I was working in a family homeless shelter. What I found there was, I found a population that was significantly at risk, vulnerable, and in need. People who were able to, with support, stay sober and stay strong, work towards finding themselves after years of dealing with addiction and mental health concerns. One young man that really stuck with me was a 20-year-old man, a Native American who was at the shelter with his family. Did quite well while he was with us and receiving support and resources, and had a sober community with him. But the second he left us, he relapsed and overdosed and died. This was someone that I, in the beginning of my career, saw lots of hope for and felt very connected to. Hit me quite hard. Since then, what I've seen is addiction really affecting the lives of multiple patient populations, from children, new mothers, to the geriatric populations. And in working with these populations, what becomes clear is, as addiction is a biopsychosocial disease affecting the person really at a holistic level. The neurological changes that happen as a result of chronic misuse of opioids, alcohol, other drugs, it really leaves a person vulnerable. It creates a state of emotional distress. We see consistently poor emotional regulation. We see people who, when they come to treatment, when they start engaging in resources, they're overwhelmed with limited personal resources. What that means for them and what that means for us as a community is, this isn't something that can be overcome alone. We need to approach the disease of addiction as a community, working together, working in cooperation and coordination. Our patients, we work very hard to connect our patients with sober groups and sober peers. We work with the family, shifting the family system and the dynamics within the family to support the changes that really need to take place within that family system to drive success long-term, to really support healthy, adaptive shifts in the person that we're working with, the person managing the addiction actively, but also the system that the addiction is occurring within. That means connecting our patients with community providers, whether it's a psychiatrist, psychologist, 12-step groups, smart recovery, peer support groups, or connecting the family with resources like Al-Anon, making sure that we don't approach this as a disease of isolation, reinforcing the isolation, but rather approaching it as a community, recognizing that the only true means of success is connecting with each other.
Thank you, Kevin. Your expertise is definitely valuable. Sydney, are there comments from the field you'd like us to relay to the panel and audience?
There's thank yous. There are thank yous, but there are no comments. Does anyone have anything that they'd like to say, or a story they'd like to share about their experience with the opioid crisis?
Sydney, while we're waiting for questions to pop up in the chat box, I'm going to throw this question out to the members of the panel who can speak up to their experience. Is there anyone who can discuss a partnership that they've developed in their community outside the medical realms to change the situation in their communities?
I can talk about the partnerships that we're developing with the school systems. One of the programs I've developed and I run at Hoag Hospital is a program that works with teens and adolescents and their families. We, in the process of encouraging their families to bring their kids to us and really driving success and destigmatizing the work that we do, we actually have worked with 2 of the school districts out here to arrange for our program to be eligible for school credit so that the kids can come to us, engage in treatment, and actually get school credit for engaging in treatment.
Thank you, Kevin. Sydney, do you have any updates from the chat box?
There are no updates.
Okay. One other question that we have for the panel is that what is it that we can do as members of our community outside of maybe our healthcare profession?
Hannah, I think getting involved with the local groups, and with the healthcare groups, with the behavioral health, the addiction, forming coalitions to assist in treatment, and having an open school of thought or open communication, having an arena of patients would be helpful.
You know, I come from it in a totally different perspective. And like I said, and when I was talking earlier, if you can immerse yourself into a recovery culture, even coming from a healthcare provider perspective, obviously when I talk to a patient who has the same history as myself, I can empathize maybe in a way that others don't empathize, but I most definitely have the resources at my fingertips. I most definitely make sure that I, sit on their level, that I reach out to them and say, you are cared about, this is not a moral issue, this is a disease process that you have the right to have treatment for, that there are bills in place, there are, such as the CARA bill that the president just signed into this year in 2016. There are people out there that care about the recovery of our nation. I also make sure that I have psychiatry and psychologists and therapy available in my community for referral. People want to get well. Nobody is born and says, I want to be an addict when I grow up. I want to be an alcoholic. Nobody thought that this could happen to me, but it happens. It happens to people in almost every walk of life, and most families have been affected by this in one way or the other. And we want to be able to, as a society, get better. And so it's most definitely taking the opportunity to say, here's a resource. Let me make sure that I check in on you and check up on you. And let me make sure that you have a telephone number to call. And also that there are people who've walked the walk, that have talked the talk and know that what you're going through. It took 12-step program for me. It took telephone numbers for me. And it took other nurses in recovery. And that's why I often go to universities and talk to nursing schools and say, hey, do you know how often this happens to nurses? It's 26% of all nurses have some sort of addiction. Do you know how common this can be? And do you know that there are ways to get into recovery without losing your license? Other mothers, other families, this is very common, but there are ways to get recovery. Here are some resources. So having the resources available, having the experts around, having those mid-level people, for instance, the physician's assistants, not just the nurse practitioners available in the emergency departments and in those kinds of places, can make such a huge difference. Nurse practitioners saved my life because they were the ones that were able to sit with me and take the time. I really appreciate the opportunity to talk about and tell my story. I am always available to do that because I know that if I give it away, I can keep it.
Sherry, we do have a comment for you from the chat box.
Okay.
Sydney?
I was going to say, Sherry, we have a question from Janie. She wants to know what you mean by the culture of immersion, recovery culture immersion.
It means that instead of just looking at it from a healthcare provider's perspective, that you look at it from the perspective of an addict or an alcoholic. It's not a lifestyle that is the typical lifestyle. You know, every single event that you go to, there's alcohol served. I recently went to the American College of Nurse-Midwives annual convention, and everywhere I went, there was this huge culture of alcohol. It didn't bother me because of my years in recovery, but for the average person, it might have been a little bit different. Everywhere I go, I need to know, where are there meetings available? How can I call a sponsor? How can I get a hold of somebody so that I know that if I need to talk to somebody, I can? Where are there places available where I can go that are not all about a party, that are not all about somebody having, you know, just going for drinks, or just, or how do I get pain relief? How do I go do my yoga or my meditation or those kinds of things? What's available out there for myself or for the recovering addict? Recovery culture, you know, I listen to podcasts, I look at blogs, I do webinars, I do all kinds of things and have those things available for my patients who might need those resources. So that's what recovery culture is. It's a whole different culture. Just like there's all kinds of cultures for almost every walk of life. There's a midwifery culture. There's a culture for healthcare. There's a culture for the Broncos. Hey, I'm from Colorado. So there's a culture for almost everything that you do. But it's a whole different language. It's a whole different way of living and a whole different walk of life. And it's also about wellness. Making sure that we're taking care of ourselves on a daily basis. We can no longer just say, hey, I'll just stay out all night and party. You just can't do that. You have to take care of every aspect of yourself, the mental self, the physical self, and the spiritual self. And I'm not talking about just one God or religion. I'm talking about knowing that you're okay from your head all the way to your heart.
Sherry, thank you. Sid, are there any more questions?
I have a question that I actually got from a text message from one of our students. She wants to know, how do we help our patients pay for other modalities such as lidoderm patches or physical therapy when our insurance companies won't cover it?
Heather, can you patch in at all? I think you're probably the perfect person to answer this question.
Regarding physical therapy and how to pay for it and other modalities?
Yes, ma'am.
Okay. You know, there is a shortage on insurance. Having handouts to give your patients, I often will work with patients on effective, cheaper exercises they can do at home. Exercise balls are great. You know, $10 to $15 at most of your local box stores. And a patient can do many stretching exercises in the comfort of their own home. I will link them up with YouTube videos, handouts, provide them with a lot of the things that they would get if they went to physical therapy, if they can't afford to go. Approach local gyms that are willing to discount services with trainers to people who can't afford payment. They will work things out. They'll do a sliding scale for memberships. They have scholarships available at the YWCAs, YMCAs in our areas. And they're willing to work with patients to get them in better health. And I think it's a matter of meeting your patients where they are, not where we assume they can be. Even those with insurance can't always afford the additional cost of physical therapy. The copays are expensive. Those things all add up. I often ask patients questions they're very shocked by. You know, when I treat a patient for pain, I want to know all about their whole being. I want to know how they're sleeping, how their mental health is, because if they're not sleeping, their pain is worse. If they aren't sleeping because they're stressed because there's no food in the home, then we link them up with the local food banks. So really knowing your local resources and having that at your fingertips and that in your toolbox is ideal. But many times you can work something out with your patients for a lower cost.
Heather, thank you. Are there any further comments from the field, Sid?
No, just comments about what a great topic it was, and people wanting to thank everybody for the questions and the answers and the sharing.
Awesome. Thank you, Sid. So some of the emerging calls to action that I heard during this session is to first acknowledge that we have a problem. The second thing is to look for ways that we can become more educated and more understanding of the recovery culture, as Sherry mentioned. In addition, we heard about taking some action through healthcare policies, whether that's in your community or in your state or at the national level. This can make a difference. Find out in your community if there are partnerships. If they need help, try to get involved. If there's no partnership, begin to ask some questions of your peers and colleagues of how one can possibly be put together. So we'd like to thank everybody for attending today's Story Slam. You will see an information link posted now to connect you with some resources that were discussed in today's forum. We hope to see you again soon for another virtual event hosted by the Frontier Nursing University Institute for Healthcare Improvement Open School Chapter. Thanks, everybody.
Thank you. Great work, you guys.
Thank you for the opportunity.
Thank you.
Thanks for having me.